Good day, and welcome to this lecture on the World Health Organization guideline for the management of uncomplicated malaria. I am Professor Shaibu Orichabello of the Department of Pharmacology and Therapeutics at Usman Danfodio University, Sokoto. Over the next series of slides, we will examine the evidence framework, diagnosis, treatment, and prevention of malaria, drawing on the WHO guidelines for malaria as updated in August 2025. This presentation is intended for healthcare professionals seeking a comprehensive and up-to-date overview. Let us begin with an overview of the WHO malaria guidelines themselves. In February 2021, the WHO launched its consolidated guidelines, bringing every malaria recommendation together onto a single platform, and these have been kept current through to August 2025. The recommendations rest on the GRADE methodology and systematic reviews, which inform prevention, diagnosis, treatment, and elimination strategies. Importantly, the guidance is living. It is reviewed continuously as new evidence emerges, and the latest version reflects revised vector control measures, new vaccines, and emerging data on drug resistance. Before we interpret any recommendation, we must understand how the evidence is graded. WHO applies the GRADE framework, which rates each recommendation on two distinct dimensions. The first dimension is the strength of the recommendation. A strong recommendation means the desirable effects clearly outweigh the undesirable ones, and most patients should receive the intervention. A conditional recommendation indicates that the balance of benefits and harms is close or uncertain, so the appropriate action may vary with patient circumstances. The second dimension is the certainty of evidence, ranging from high through moderate and low to very low. As a practical rule, a strong recommendation supported by high certainty should be applied broadly, while lower certainty does not by itself invalidate a strong recommendation when the benefits clearly outweigh the risks. You will also encounter the levels of evidence classification, labeled A through D, which rates the quality and type of study data. Level A denotes high-quality evidence from multiple randomized controlled trials or meta-analysis. Level B reflects moderate quality evidence, typically from a single trial or well-designed non-randomized studies. Level C indicates low-quality evidence from observational or underpowered studies, and Level D represents expert opinion based on clinical experience or case reports. It is worth noting that WHO primarily uses the GRADE framework, whereas the A to D system is favored by bodies such as the ACC or AHA and ESC, and may appear in the source studies that WHO references. To appreciate why these guidelines matter, consider the global burden. In 2024, there were an estimated 282 million cases worldwide and approximately 610,000 deaths, with 95% of those deaths occurring in the WHO African region. The 2025 World Malaria Report records 9 million more cases than the previous year. Most deaths occur in children under 5. Encouragingly, new tools such as dual ingredient nets and vaccines prevented an estimated 170 million cases and 1 million deaths. and 47 countries plus one territory have now been certified malaria-free. We now turn to diagnosis. The core principle is unambiguous. Every suspected malaria case should receive a parasitological test, either microscopy or a rapid diagnostic test to confirm the diagnosis before treatment. Test selection depends on the clinical setting. Rapid diagnostic tests are well suited to uncomplicated malaria, to health posts and community health workers, and to periods of heavy patient load. Microscopy is require severe malaria on admission and for the assessment of treatment failure. Results should ideally be available within 2 hours. Where they are delayed, suspected severe malaria and high-risk groups should be treated on clinical grounds. This recommendation for parasitological confirmation is strong and supported by high certainty evidence. This slide examines the predictive values of our two diagnostic methods. The underlying performance is strong. PHAP2 based rapid tests offer sensitivity of 95 to 99%, while PLDAH based tests and expert microscopy provide higher specificity. However, the positive and negative predictive values shift markedly with prevalence. In high transmission settings, the positive predictive value remains high, but as parasite prevalence falls below 5%, the positive predictive value of PHAP2 rapid test can drop to as low as 17%. The negative predictive value, by contrast, stays high across all settings. This relationship is essential to understand before interpreting any single result. Here we translate those predictive values into clinical decision-making. In high prevalence settings, the positive predictive value exceeds 90% for both methods. So a positive result strongly indicates true malaria. False positives are infrequent, and rapid tests perform comparably to microscopy. In low prevalence settings, the picture changes. The positive predictive value of a rapid test can fall dramatically, meaning many positive results may be false positives. So confirmatory testing or clinical correlation becomes essential before treating. The key takeaway is that positive predictive value is prevalence dependent, while the negative predictive value of both tests remains excellent across all settings. To ground these statistical principles, consider the geographical distribution of malaria. Countries fall into broad categories by parasite prevalence in children under 5. High prevalence countries with rates above 25% include Nigeria, which alone accounts for 26% of global cases, along with Burkina Faso, Mozambique, and others. Moderate prevalence countries such as the Democratic Republic of Congo and Uganda fall between 10 and 25%, while low prevalence settings below 10% include Senegal, Rwanda, and parts of Asia and the Americas. These figures derive from WHO World Malaria Report 2025. Let us look more closely at Nigeria, the highest burden country worldwide, responsible for 26% of global cases and 31% of global deaths. According to the 2021 Malaria Indicator Survey, the national average parasite prevalence by microscopy is 22%, but there is striking regional variation. The northwest zone carries the highest burden at 30% by microscopy, while the southwest records the lowest at 16%. Note too the consistent gap between rapid test and microscopy figures, which reflects the antigen persistence we discussed earlier. This slide sets out the rationale for matching specific tests to specific clinical scenarios. Rapid diagnostic tests are preferred where infrastructure is limited at community health posts for the initial diagnosis of uncomplicated malaria, and during epidemics or heavy patient loads, because they need no electricity, require minimal training, and deliver results in 15 to 20 minutes. Microscopy, however, is required where quantification or species identification matters in severe malaria on hospital admission, in the follow-up of treatment failure, and in therapeutic efficacy studies. This is because rapid tests cannot measure parasite density, and HRP2 based tests can remain positive for weeks after successful treatment, making them unsuitable for distinguishing true recrudescence from residual antigen. Understanding the operational requirements of each method helps in planning services. Light microscopy demands a binocular microscope with oil immersion optics, gene-sustaining materials, a reliable electricity supply, and a trained microscopist with WHO competency certification, together with quality assurance through slide cross-checking. Turnaround is typically 30 to 60 minutes per specimen. Rapid diagnostic tests, by contrast, require only pre-packaged cassettes and buffer, need no electricity, and can be performed by community health workers after brief training. They must be stored below 40 degrees Celsius, and only WHO pre-qualified products should be used. They deliver results in 15 to 20 minutes but cannot quantify parasite density or monitor treatment response. We now move to treatment for uncomplicated Plasmodium falciparum malaria. The WHO recommendation is to treat with an artemisinin-based combination therapy, or ACT. The logic of combination therapy is elegant. The artemisinin derivative rapidly reduces parasite biomass over the first 3 days, while the partner drug, which has a different mode of action, eliminates the remaining parasites and protects against resistance. The standard 3-day course covers 2 asexual parasite cycles. In low transmission areas, a single low dose of primaquine may be added to reduce transmissibility. Critically, artemisinin monotherapy must be avoided to prevent resistance. The recommendation for ACTs as first-line therapy is strong and based on high certainty evidence. WHO currently recommends 6 artemisinin-based combination therapies. These are artemether lumefantrine, artesunate amodiaquine, artesunate mefloquine, artesunate pyranardine, artesunate plus sulfadoxine pyrimethamine, and dihydroartemisinin piperaquine. Each pairs a rapidly acting artemisinin component with a longer acting partner drug. The choice of regimen should be guided by local efficacy data and national treatment policy, and once again, artemisinin monotherapy must never be used. Treatment of Plasmodium vivax and Plasmodium ovale requires attention to 2 stages of the parasite. For the blood stage, chloroquine or an ACT is used in chloroquine sensitive areas while an ACT is required where chloroquine resistance exceeds a 10% failure rate, a growing problem in Oceania and parts of Southeast Asia. The liver stage demands radical cure to eliminate dormant hypnozoites and prevent relapse. This is achieved with an 8-aminoquinoline, either a 14-day or 7-day course of primaquine, or a single dose of tafenoquine, because these drugs can cause hemolysis. Glucose 6-phosphate dehydrogenase testing is required before administration, which leads us to the next slide. Radical cure carries an important safety consideration. Both primaquine and tafenoquine cause dose-dependent hemolysis in individuals deficient in glucose 6-phosphate dehydrogenase. So G6-PPD testing is essential before use, where G6-PPD activity is normal, above 70%, standard primaquine or single-dose tafenoquine may be given. In mild to moderate deficiency, between 30 and 70% activity, primaquine may be given at a lower weekly dose over 8 weeks under supervision, while tafenoquine is contraindicated. In severe deficiency below 30%, both drugs are contraindicated, and the patient is managed with blood stage treatment alone, with monitoring for relapse. Special populations require tailored approaches, beginning with pregnancy. A significant update in 2022 made artemether-lumefantrine the preferred first-line treatment in all trimesters, including the first. This replaced the former recommendation of quinine plus clindamycin and is supported by a meta-analysis of more than 34,000 pregnancies, showing 42% fewer adverse outcomes compared with oral quinine. In the second and third trimesters, all recommended ACTs may be used. Intermittent preventive treatment with sulfadoxine pyrimethamine is advised for prevention, and primaquine and tafenoquine remain contraindicated throughout pregnancy. Children and infants bear the greatest burden of malaria mortality, so their management deserves particular care. Infants under 5 kilograms should receive an ACT at the same milligram per kilogram target dose as a 5-kilogram child, with close monitoring given the limited pharmacokinetic data. Children under 5, in whom most deaths occur, require prompt diagnosis and weight-based ACT dosing. For those with suspected severe malaria who cannot take oral medication, rectal artesunate should be given as pre-referral treatment before transfer. And in HIV co-infection, drug interactions must be considered. Avoid artesunate plus sulfadoxine pyrimethamine with cotrimoxazole, and avoid artesunate amodiaquine with efavirenz. We must now address a growing threat: artemisinin partial resistance. This is defined as delayed clearance of parasites from the bloodstream following ACT treatment. It affects only the ring stage of the parasite cycle, which is why it is termed partial, and on its own it does not necessarily cause treatment failure, but it places greater demands on the partner drug. Originally emerging in the greater Mekong subregion, partial resistance is now confirmed or suspected in at least 8 African countries, and multi-drug resistance is seen in parts of the Mekong. The WHO response emphasizes continuous monitoring of antimalarial efficacy, framed by a strategy to respond to antimalarial drug resistance in Africa. Prevention through chemoprevention is a major pillar of malaria control. Intermittent preventive treatment in pregnancy using sulfadoxine pyrimethamine at each antenatal visit from the second trimester is a strong, high certainty recommendation. Perennial malaria chemoprevention now protects infants and young children, replacing the former IPT and delivered through the immunization platform. Seasonal malaria chemoprevention delivers curative doses during the malaria season and reached 54 million children in 2024. Intermittent preventive treatment is also being extended to school-aged children, and post-discharge chemoprevention is recommended on a conditional basis. Among the most exciting developments are the malaria vaccines. The RTSS vaccine, recommended by WHO in October 2021, was the first given as a 4-dose series for children in moderate to high transmission areas. The R21 vaccine, recommended in 2023, offers higher efficacy in trials and is easier to manufacture at scale. 24 countries have now introduced malaria vaccines into routine immunization. Beyond vaccines, other emerging tools include dual-ingredient insecticide-treated nets, which combine pyrethroid with chlorphenapyr and are recommended over pyrethroid-only nets in areas of resistance, and spatial repellents, a new conditional recommendation based on recent evidence. Turning to the broader goal of elimination, 47 countries and 1 territory have been certified malaria-free to date. Recent milestones are encouraging. In 2024, Cabo Verde and Egypt achieved certification, the first African island state and the North African milestone. And in 2025, Georgia, Suriname, and Timor-Leste were certified, spanning 3 WHO regions. Yet progress against global targets is mixed. The mortality rate of 13.8 deaths per 100,000 is more than 3 times the global target of 4.5, and case incidence rose by 9 million in 2024. Funding gaps and drug resistance continue to threaten these hard-won gains. Let us consolidate the key messages. First, artemisinin-based combination therapies remain the cornerstone of treating uncomplicated falciparum malaria, with 6 regimens recommended. Second, artemether-lumefantrine is now first line in all trimesters of pregnancy. Third, radical chloroquine with ortofranoquine is essential for the Vivax malaria, but requires G6PD testing. Fourth, artemisinin partial resistance is spreading and is now confirmed or suspected in more than 8 African countries. Fifth, the malaria vaccines are transforming prevention, with 24 countries having introduced them. And finally, national programs must continuously adapt their treatment policies based on local efficacy monitoring. For those who wish to study further, this slide lists the primary sources underpinning this presentation. These include the WHO Guidelines for Malaria of August 2025 and November 2024, and the World Malaria Report 2025. Additional references cover drug resistance, treatment in special populations, and radical cure with G6PD testing. All sources were accessed in May 2026, and the full guidelines are available through the WHO Global Malaria Program website. That brings us to the end of this overview of the WHO guideline on the management of uncomplicated malaria. I thank you for your attention. Should you wish to discuss any aspect of this material further, my contact details are provided on the slide. I encourage you to consult the full WHO guidelines as you apply these recommendations in your own clinical and public health practice.